morning, everyone, and welcome to our first ID/IIDR rounds of the 2022-23 year. I'm Laurie Burrows. I'm the Associate Director of the Michael G. DeGroote Institute for Infectious Disease Research, and I am your host today. I'm very happy today to introduce our speakers, Dr. Dominik Mertz and Dr. Debbie Yamamura, who will be joined by a PhD student from my lab, Victoria Coles. So they're going to be talking today about therapies and clinical trials for Staphylococcus aureus. So let me just give you a brief bio. So Dominik is an infectious disease physician, a hospital epidemiologist, and the division director of infectious disease for McMaster's Department of Medicine. He has a keen interest in antimicrobial resistance in the hospital setting and will be speaking to us today about an upcoming multinational randomized control trial on Staph aureus. And he will introduce Dr. Deb Yamamura when she jumps in for a few slides. Victoria Coles is a PhD candidate in my lab. Her research involves using biofilm stimulation to identify novel antibiotics and antibiofilm agents to treat multi-drug resistant infections. And today she's going to be discussing some of her research for a potent compound that treats MRSA, and it has the ability to potentiate beta-lactam antibiotics. So thank you everyone for joining us and our speakers for sharing their exciting research with us today. So Dominik, I will pass the floor over to you.
So good morning, everyone, and thanks for having me. Happy to talk about the first part of our journey with Staph aureus, looking at what do we have to learn now about things that we had been doing and people do it slightly differently. And then we will hand it over to Victoria to talk about what the future may hold for us in terms of Staph aureus treatment. This is what I would like to cover. So quickly touch on the knowledge gaps in Staph aureus bacteremia management. I could probably talk a couple hours on this, and I try to get everything within 20 minutes. So please bear with me. I will introduce the SNAP trial platform, which is this trial that Laurie referred to, and then go through the domains and silos. And once I show you the study design, you will understand what I mean by domains and silos. So why is it important? We have an estimated 15,000 episodes of Staph aureus bacteremia in Canada, a case fatality rate estimated in a range of 23%, depending on how you're measuring it. We done a retrospective review back in 2011 and 12 on management of Staph aureus bacteremia. We found an in-hospital mortality of 28% in that population. In trials where you typically exclude the most severely sick patients, mortality is typically just below the 20% mark here in the DASH trial and CAMERA 2 trial that we will come back to. Now, thinking about such a significant infection that we see pretty much daily in infectious diseases, there's a scarcity of RCTs. In total, 798 MRSA Staph aureus bacteremia patients have been enrolled in RCTs, a total of 2,322 Staph aureus patients. So many of the things we do without any RCT evidence. We are fairly standardized, I would say, when it comes to, yes, we need an ID consult, we need to repeat blood cultures, we have to remove lines if they are supposed to be or thought to be the source or potentially colonized, and we do an echocardiography. But there's a lot of variability. Which antibiotics are being used? What doses? Is there oral step down at all? And if so, when? The total duration. And again, last weekend, I came across a trainee who told me, well, 14 days from first negative. No, that's not in the guidelines. That's a generalization from what we do for candidemia. Is it wrong? Nobody really knows, right? Because we've never done the studies. Or escalating if no clearance within 3 days with combination treatments and so on. So bottom line is it results in random care. Depending on who your attending physician is, you may receive different management for your Staph aureus bacteremia There might be differences in local practice, where, depending on the hospital site that you may end up in, and what resources are available. Can you afford daptomycin, yes or no? The team did a survey in 2019 among the AMMI members, so the Infectious Disease and Micro Society of Canada. First question was, patient with presumed uncomplicated, Penicillin susceptible Staph aureus bacteremia, what the preferred regimen is. You see 2/3 chose Cefazolin, 22% Cloxacillin, some others, as you can see here. 90%, almost 90% said they are willing to randomize Cefazolin versus Cloxacillin. So there's an agreement that there's clinical equipoise here, whether one or the other might actually be superior. In uncomplicated PSSAs or penicillin susceptible Staph aureus bacteremia, the majority said, I would stick to my original IV choice, so Cefazolin or Cloxacillin, while only 30% would say, I switch to IV penicillin. 2/3 are willing to randomize to either Cloxacillin versus penicillin here. They also looked whether people are willing to randomize patients in Staph aureus bacteremia to standard therapy versus 7 days of adjunctive clindamycin. And you can see 3 out of 4 said, yes, there's clinical equipoise on that question as well. And if, assuming good clinical response, would you step down to all therapy? And that's only a small minority that is doing that, either rarely or sometimes. In most cases, people would not. So still a lot to learn, and SNAP as a platform, as a research platform, tries to address these questions that I just mentioned, but is also a platform that allows us studying other questions that are in the pipeline being considered at this point. But the goal is really to move from random to randomized care. SNAP is highly pragmatic. As you can see also when you look at the inclusion criteria, every patient with Staph aureus in a blood culture who's admitted to a hospital that participates is eligible. And then there's a relatively small number of exclusion criteria on the right, and I don't have time to go through those in detail. It's open label, again, makes it much easier for us to roll out a trial like that. It's an adaptive design, and just to give you an idea of what an adaptive design is, very superficially though, is, well, you collect data, you analyze the available data on a recurrent basis, you have certain stopping rules. If those are met, a certain research question or a norm may be dropped off. You may adapt the protocol, or not necessarily the protocol, but you may adapt the question or how you randomize, and you keep going until that question is also answered and the stopping rules are met. And it's a platform, and certainly platform studies aren't an ID invention. I think the one that people may be most familiar with is REMAP-CAP, which uses a similar platform. This is a New England Journal of Medicine article that I can highly recommend if you're interested in reading around platform trials. SNAP is an Australian-led international multi-center investigator-initiated trial platform. There's multiple simultaneous questions using a Bayesian framework. We'll come back to that. The funding for the Canadian sites is through IIDR, and there's currently funding requests pending for, I believe, 2 additional research questions is what we landed on eventually. And this is the bigger picture. So the outer circle is your Staph aureus bacteremias in hospitalized patients at the participating center. You try to get as many of those patients at the minimum in a registry, which allows you some observational, to address some observational research questions. Obviously, the goal is to recruit as many as possible into the SNAP trial platform, where then there are 3 domains that I will come back to. in which they get randomized to different types of management strategies. And this slide shows you what those silos are. So the silos are PSSA, so penicillin susceptible Staph aureus, MSSA, methicillin susceptible, MRSA, methicillin resistant Staph aureus. And you have three domains: antibiotic backbone, you have your adjunctive treatment domain, and you have your early oral switch domain. If you have a PSSA, you get randomized to either Cloxacillin or Penicillin. You get randomized to either adjunctive clindamycin or not, and you get randomized to either early oral step down or not. And there's criteria that you have to meet to be eligible for oral step down. In very short, you have to be stable at day 7 and have uncomplicated disease, then you're eligible for oral step down randomization. If you have complicated disease, it's on day 14. If it's MSSA, it's either Cloxacillin or Cefazolin, and the other two domains I mentioned. If it's MRSA, it's either Vancomycin or Vancomycin plus Cefazolin, and the other two domains. Some scientific background as to why we believe those are important research questions. So first, clindamycin adjunct. First, mortality reduction was shown in animal models and observation studies, but as we all know, that may or may not translate into humans. As you know, Staph aureus, similarly to group A strep, produces a variety of toxins that can be inhibited by clindamycin. We also know about the eagle effect of beta-lactams. Clindamycin can overcome that and also works for bacteria in the stationary phase. And what happens with clindamycin at the point of time that you know someone has a Staph aureus, you get enrolled in either with or without clindamycin, regardless of whether eventually you are identified as having PSSA, MSSA, or MRSA. And it's regardless of the susceptibility test results for clindamycin, because here it's really about synergism, for which we don't really have a breakpoint. All of those subdomains have some specific inclusion and exclusion criteria. The most important additional exclusion criterion for the clindamycin piece is if you had C. diff in the last 3 months, you will not qualify, or if you had recurrent C. diff in the last 12 months, given the risk of C. diff with clindamycin. Penicillin versus Cloxacillin for PSSA. PSSA is re-emerging. It's up to 25% of Staph aureus isolates in some region. Penicillin has a lower MIC, less phlebitis, less hepatotoxicity, less renal toxicity than Cloxacillin. Observation studies suggest a higher mortality risk with Cloxacillin. And the risk that sort of remains is, and that's why some people don't feel comfortable with it at this point, is the misclassification of, you think it's PSSA, but in fact, it's penicillin resistant. And for that, we went through a lab validation that Dr. Yamamura, our microbiology lead for the trial, will guide you through. I just want to mention, when I trained back in Switzerland, I was used to treat Staph aureus bacteremia with penicillin, and then I came here and was taught, no, we don't even test for that. So for me, it's sort of going back to how I trained and actually use penicillin when I can for Staph aureus bacteremia. But over to you, Dr. Yamamura, to guide it through the validation that you've done.
Sure, thanks, Dominik. So you would think that susceptibility testing for penicillin would be standardized because it's such an older agent. We do know that resistance is due to penicillinase production, but in fact, testing is quite variable in clinical labs. So there are several options, and actually what we currently do is we do not test and report, meaning we don't release any results for penicillin. And this was based on the fact that previously it was thought that there were very high rates of penicillin resistance. However, in multiple geographic areas, this is not shown to be the case. So the other option is you can test with just an MIC only. And usually this is using one of the automated systems. But the risk of this is that you'll miss the detection of some penicillinase production. So the isolate will look susceptible by MIC, but in fact, it does produce a penicillinase. So as Dominik has mentioned, clinicians were a little bit reluctant to use penicillin. So there is an additional test that can be done so that if your MIC looks like it's susceptible, you can add a penicillin disc diffusion and you actually look at the edge. So this is the difficult part because it's a little bit subjective. So I've shown you two pictures. In this picture, you can see that the zone diameter is quite wide, so it's susceptible. This is considered to be the fuzzy edge. So sometimes they describe this as the beach. So if you see this, then you know that it is penicillin susceptible. However, if you have a sharp edge, then you know it's penicillin resistant. If you change the slide. So what SNAP did is they actually did a laboratory validation, and this included 34 testing sites. It was international. Our site was one of the sites, and they sent us 27 well-characterized Staph aureus isolates. There were actually 9 isolates with 3 replicates, but we were blinded to this. And the gold standard was the detection of BLAZ PCR. So the options for the labs were to either use the UCAS, which is the European guidelines, or CLSI. So our lab decided to do both. So the results were that if you use the CLSI method, if you compare the results to the PCR for the penicillinase, that's considered to be most significant, there is an 85% overall agreement, but with quite a high, very major error rate of over 20%. If you use UCAS, the agreement was much better with a lower rate of very major error. And if you look at the two methods, the main difference is the concentration of penicillin in the disc, and then the zone diameter, what you consider to be susceptible or resistant. So the SNAP validation group decided that the UCAS method was preferred, but they would still allow either method to be used during the trial. Next slide. This just gives you an idea, looking at these 27 isolates, that if you use a CLSI method with the zone diameter, you can see that the range of isolates with the penicillinase actually crosses over that zone diameter. Whereas with the UCAS method, it is a little bit better at discriminating. So you can use the objective method of measuring the zone diameter and knowing it's resistant with the UCAS and capture more of the isolates. When you add in the edge zone diameter, which is more subjective, you can see that you can have things that are fully susceptible, but you will pick up more of the BLAZ if you use that fuzzy edge, but that's subjective. And that's probably where we see most of the variability. Next slide. This just gives you a different description of the isolates that were sent to us. Dominik, can you just click to go forward? And this was these were the isolates that were most problematic for the testing site. So you can see that with this group, overall, the MIC was actually very susceptible. And it just shows that using that subjective measurement of looking at whether it's fuzzy or sharp did result in quite a few of the errors. Next slide. So one of the things that the validation study felt that with the isolates that were missed, most of them had very, very low MICs. And they felt that the amount of the penicillin dosing would result in clinically, it would not be as significant. So that's why they felt comfortable going ahead with doing the penicillin silo. And this, I won't go into detail, this just shows a SNAP laboratory protocol. But the penicillin testing is very important for our site to be able to look at either the penicillin susceptible silo, but also the Cloxacillin versus Cefazolin, because one of the things that is still a question is whether Clox versus Cefazolin is impacted by the presence of penicillinase. So they really need the labs to do that testing. So we will be incorporating that into our routine clinical practice. Okay, that's it. Thanks.
Okay, thank you very much, Deb. The next domain was cell, I would say, is Cloxacillin versus Cefazolin for your MSSAs. Listing here on the left-hand side the advantages of Cloxacillin. It's actually the majority of prescribers are using that in Australia, in contrast to Cefazolin, which is used by the majority of prescribers in Canada. Cloxacillin is recommended in the IIDR and European Society Guidelines for Endocarditis. And you have the concern that high levels of penicillinase may reduce the Cefazolin stability through an inoculum effect, which wouldn't apply to Cloxacillin. On the other hand, for Cefazolin, we have lower nephro and cytotoxicity, we have less frequent dosing, and we have, in fact, multiple observation studies that have suggested Cefazolin may, in fact, be superior. And then we have the Vancomycin plus minus Cefazolin for MRSA arm. Vancomycin can be replaced by daptomycin. There's the CAMERA 2 trial here with 352 patients with MRSA bacteremia. And again, they used Vanco or Dapto with and without the beta-lactam. Most Cloxacillin have been used here. And what you can see here on the right-hand side is there's quicker clearance in the combination arm. However, there's a significant increase in acute kidney injury, and they looked at, okay, which regimen those people received, and it was first and foremost Cloxacillin. So that's why the combination will be Cefazolin and not Cloxacillin because of the AKI, acute kidney injury signal. What do we know about IV versus oral switch, which is the last domain that we would randomize patients to? You're all aware that the concept of it has to be IV antibiotics is being questioned more and more, while in the past there was sort of a religious belief that everything has to be IV. We have the POET trial for endocarditis, we have the OVIVA trial for bone and joint infections, which showed earlier switch to oral results in the same outcomes as continued IV treatment. You can reduce costs, nursing resources, you can eliminate central lines with all the risks associated with those. However, again, there's specific in and exclusion criteria for this domain because we don't want to transition people to oral treatment where they may have, in fact, a higher risk of recurrence. And as I already mentioned, it's the definition of uncomplicated versus complicated Staph aureus bacteremia. And depending on into which category you fall, you're either eligible on day 7 or 14, as long as you're stable and your cultures have cleared. And there's a menu of oral choices that are provided. In general, beta-lactams for PSSA, MSSA, and they prefer linezolid for MRSA. But it's the clinician's decision which one to use. But these are the recommended agents depending on into which cell you fall in terms of PSSA, MSSA, or MRSA, and whether you were initially randomized into one or the other study arm. And again, I will not go into the details. These are all options that have been used in other oral treatment studies. So how does the enrollment then look like? And I will guide you here through this patient pathway from the top to the bottom. So in the top, you have to meet your core inclusion criteria, so positive blood culture plus in a hospital. And then the question is, any exclusion criteria? If yes, you try to get the patient into the registry. If not, well, then there's nothing further you will do with that patient. If they don't meet exclusion criteria, you try to consent them into the actual trial. Again, if they don't want to do that, you still try to get them into the registry. And if consent is given, then they enter the platform. And all of this should happen within 72 hours of the index blood culture collection. As mentioned, the first step will be, and that's within 4 hours from platform entry, if the patient is willing, getting randomized to either added clindamycin or standard of care without clindamycin for the 5 days. And clindamycin can be IV or PO. Then once you know whether it's a PSSA, MSSA, or MRSA, then you will be made aware of the randomization for this specific cell that the patient is in. So if it's PSSA, as I mentioned, it's either Cloxacillin or Penicillin and so on. And then on day 7, the question will be, does the patient meet the criteria for early oral switch on day 7? If so, again, then the randomization will be revealed and you continue IV or you switch to oral. If not, patients continue on IV until day 14. Again, same question asked. If they qualify, then they would get randomized. If not, they stay on IV treatment. What are the primary outcomes, or the main outcomes? I would say primary outcome is 90-day mortality, all-cause mortality. And then there's a long list of secondary outcomes plus domain-specific secondary outcomes. So I will not talk about all of them, but some key ones are all-cause mortality at different time points, lengths of stay, microbiological treatment failure, new metastatic foci, C. difficile, serious adverse reactions at day 90, and as I mentioned, many more. From a statistics perspective, as I mentioned, it's a Bayesian approach. The first interim analysis will be done after the 500th patient has reached 90-day follow-up, and then there's regular data analysis after every 500 more patients, and it will be assessed for either, depending on the research question, non-inferiority, superiority, or futility. It's a simple one-on-one randomization in each domain and silo at the beginning, but in the future could be a responsive adaptive randomization where it would no longer be a one-on-one depending on needs. And as I mentioned, future can add additional domains. These are the research questions that we would start off with. So for PSSA, backbone, it's a question of non-inferiority. Is penicillin non-inferior to Cloxacillin? For MSSA, same, it's a non-inferiority question, whether Cefazolin is non-inferior to Cloxacillin. But if that's met, they would continue to enroll to look for superiority of one of the two arms. And with MRSA, it's a question of superiority for the combination treatment. For adjunctive clindamycin, it's a question whether that's superior. And for early oral substitution, it will be a question of non-inferiority, whether you achieve the same outcomes with early oral step down versus continued IV. There's a lot of resources on the web from our Australian colleagues, but as you can see, there's also a French version for our Canadian patients and healthcare providers available, so all on their website. As I mentioned, SNAP is led by the Australian group, Stephen Tong and Josh Davis. Most sites are in Australia and New Zealand, as you can see. Currently on board is Singapore, Israel, and Canada. UK has received funding recently and will be added as well. The Canadian lead investigators are listed here as well. It's for Mitchell, Matthew Cheng, and Todd Lee, and from Toronto, Jenny Johnson and Nick Damon. The Hamilton leads, and this is my last slide, myself plus a site lead for the Churvinsky. Site lead at the channel will be Andrew Kapoor, microbiology lead I introduced today, Deb Yamamura. We do have a new study coordinator, and I like to use this opportunity to introduce him as well, Shakib Elliott, who will be coordinating this trial here in Hamilton. St. Joe's is coming on as well with St. Charles as the lead. There's a PEDS arm of all of this, so hopefully the PEDS side will be joining as well. And then there's others supporting this endeavor. Neil Irvin, our pharmacist so far, was interested, and we are more than happy to include others if you're interested in helping us launching this trial, hopefully in the next few weeks. Thank you very much, and then I will hand over to Victoria.
Thank you. So now that we know a little bit more about how staph is treated clinically, I'm going to focus a little bit more on the antibiotic pipelines and some work that we're doing in the lab. to try to identify new anti-staph compounds. So to start off with kind of where we're at in terms of new antibiotics being recently approved and coming into the pipeline to treat Staph aureus, there are a few major strategies for identifying these compounds. The first one is derivatizing already existing anti-staph compounds. So things like ortavancin, which is a relatively recently approved analog of vancomycin, and is used primarily for staph skin infections, but does have some activity against bacteremia. There's also things like ceftobiprole, which is a cephalosporin antibiotic approved for treating community and hospital-acquired Staph aureus pneumonia, but is currently under clinical trials for treating bacteremia. So those are some kind of recently approved approaches in derivatizing new antibiotics. Another approach is identifying virulence inhibitors. So things that inhibit something about Staph aureus that contributes to its pathogenicity. So there are a variety of different examples of this, some of which are being Carbex funded right now. So for example, there's an alpha hemolysin inhibitor being investigated as a potential virulence inhibitor. There's also the approach of identifying antibiotic potentiators. So a non-antibiotic molecule that helps potentiate an existing antibiotic. So the most common example of this is, of course, our beta-lactam, beta-lactamase inhibitors. And there are a couple of more relatively recently approved examples that I've listed here. The fourth approach is, of course, developing entirely new antibiotics with new mechanisms of action. But this is the slowest part of the pipeline, and there's kind of the least available in terms of new anti-staph compounds with novel mechanisms of action. But today I'm going to talk a little bit about some of the work that I've been doing in the lab to try to identify a compound which possibly kind of straddles categories 3 and 4 as having some novel activity and the ability to potentiate existing antibiotics. Before I get into that, I'm going to take a step back from all of the Staph aureus talk and switch gears a little bit to tell you a little bit about Pseudomonas aeruginosa. So Pseudomonas is a gram-negative pathogen, and like many other bacteria, it can either exist in this planktonic growth state, or it can adhere to surfaces and other bacteria and start excreting extracellular matrix components to form this community of bacteria encased in this self-produced slime known as biofilm. And being a part of a biofilm has a variety of different advantages for bacteria. Namely, bacteria in biofilms tend to have increased antibiotic resistance compared to their planktonic counterparts. But one particularly interesting, for our purposes, phenotype of biofilms is that if you treat a biofilm-forming bacteria like Pseudomonas with a low concentration of some antibiotic to which it's susceptible to, so a sub-inhibitory concentration of the antibiotic, instead what you see is this huge explosion and this large amount of biofilm being formed, likely as some sort of stress response to the bacteria sensing this low concentration of antibiotic in their environment. So to give you a sense of what this would look like graphically, here I'm showing planktonic growth in yellow and biofilm formation in purple for Pseudomonas aeruginosa across the y-axis, and then across the x-axis I have increasing concentrations of an antibiotic. So obviously, as you increase the concentration of antibiotic, you see a decrease in planktonic growth. But what you also see is this huge spike in biofilm formation. And highlighted here in this box, you can see that you start to see this spike in biofilm formation before you start to see the decrease in planktonic growth. So this means that we can use biofilm stimulation as an early indicator of antibiotic activity. So this is exactly what we did. We screened a library of about 4,000 compounds against Pseudomonas aeruginosa to look for things that would cause that spike in biofilm formation as an early indicator of antibiotic activity. And we found 60 biofilm inhibitors, including this molecule right here, BAY117082. BAY is a synthetic anti-inflammatory that was originally pursued by Bayer Pharmaceuticals in the 90s and subsequently abandoned. We showed through our assays that at low concentrations, it stimulates Pseudomonas biofilm formation, and at higher concentrations, it has anti-pseudomonal activity. But we were curious what other sorts of activity this molecule would have on other types of bacteria. So we tested it against a variety of lab and clinical strains to see what types of activity it has. So here I'm showing growth of bacteria in blue and no growth in white, with increasing concentrations of Bay across the x-axis here. And as I'm sure you can appreciate, this compound is most potent against our gram-positive bacteria, specifically against strains of MRSA. So that's where staph comes back into the story, as we chose to switch gears again and focus in on the activity that Bay has against MRSA strains. So in doing this, the first question that we asked was, can we develop a synthetic analog of Bay that is optimized to be more potent against MRSA? So in order to do this, the first thing we had to do was synthesize Bay. So we teamed up with a group of synthetic chemists in the Magdalene lab here at McMaster, who helped us devise this one-step synthesis to Bay that allowed us to vary what was on the left or the right side of the molecule, so we could change the substituents with the goal of optimizing its activity. So using this approach, we developed a variety of synthetic analogues, just a couple of which I've shown here. And some of them, highlighted in blue on the left here, have improved activity compared to the original parent molecule. But we still wanted to see if we could get even more potency, specifically against MRSA. So we ended up switching to an alternate scaffold. So we employed this molecule here on the right, PSPC. This molecule is chemically very similar to Bay. The only major difference is it contains this additional pyrazine ring, which on Bay would kind of land right above the double bond here. So just a couple of changes, slightly bigger molecule, slightly more places for us to add different chemical substituents and play around with it to try to optimize it. So again, with our amazing chemistry collaborators, we devised a synthetic route to this molecule, and we synthesized a variety of synthetic analogues again. And this time we were able to find even more that are more potent than the parent molecule. So highlighted in blue here, we've got a couple of compounds with MICs in the sub-micromolar range against MRSA strains. So that was very exciting to see. Of course, the big question moving forward was, what is the mechanism of action for Bay and PSPC and all of their chemical analogs? How is this family of molecules working to inhibit the growth of MRSA? So to begin to answer this question, what we did was we plated MRSA on agar containing either Bay or PSPC and waited for spontaneous mutants to pop up. Interestingly, we weren't able to get any spontaneous mutants. So on one hand, this tells us that Bay and PSPC likely have a low frequency of resistance, but it was also surprising and a little bit frustrating that we weren't able to isolate any resistant mutants. So we ended up switching to a different strategy where we grew liquid cultures of MRSA and continually exposed them to consistent concentrations of either Bay or PSPC for a period of 14 days in an attempt to slowly build up tolerance to the molecule. And we did end up isolating strains that were resistant to Bay and PSPC. So here in the graphs on the bottom, again, I'm showing growth of MRSA in blue and no growth in white. At the top, I have my unpassaged parent MRSA strain. And then you can see that our Bay resistant mutants have an MIC of about 4 times that of the unpassaged parent. Interestingly, we also found that mutants that were raised to be resistant against PSPC are also resistant against Bay and vice versa. So that tells us that these two compounds not only look very similar, but they also have the same mechanism of action. They're acting in the same way, and there's some conserved pathway that we're hitting here. But of course, that still doesn't answer our big question, which is, what is that conserved pathway? How are these molecules acting? So to try to figure that out, we sequenced the genomes of a variety of our resistant mutants and looked for mutations in single nucleotide polymorphisms that would be associated with this gain of resistance. And much to our surprise, we weren't able to identify any consistent mutations among our Bay and PSPC-resistant strains, particular genetic cause for resistance. So this left us with a lot of questions, and we started to wonder multiple mechanisms of action and multiple routes of resistance, and that might explain our kind of lack. We also wondered if the compounds are acting via a more general mechanism. So to try to answer that second question, we tested whether the compounds had any effect on bacterial proton modem force. So to do this, we used the fluorescent dye DISC35. So this is a fluorescent dye that's taken up through the bacteria and accumulates in the cytoplasm where it self-quenches. So if you have an antibiotic like valinomycin, which inhibits the proton modem force, it will inhibit uptake of this fluorescent dye, so it won't accumulate in the cytoplasm and won't self-quench. So you'll end up with a very high levels of fluorescence. Bay and PSPC, however, resulted in very low, very consistent levels of fluorescence, indicating that these compounds were not inhibiting the proton modem force. So back to our original question of what do Bay and PSPC do to MRSA? We still don't know, but we've at least narrowed down a couple of things that these molecules don't do. And this is still an area of active investigation and something I'm trying to figure out in the lab. But one very interesting finding that came out of this that I'll tell you about just kind of in this last part of my talk is that we found that Bay and its synthetic analogues synergize with some beta-lactams against MRSA strains. So here I'm showing a checkerboard assay. So again, I've got growth of MRSA in blue, no growth in white. And across the y-axis, I have increasing concentrations of Bay, and then across the x-axis, increasing concentrations of penicillin G. So when you combine these two compounds, you get this characteristic staircase pattern in the graph. And this is indicative of the two compounds potentiating each other. We can also represent this potentiation phenotype numerically using this FICI, or fractional inhibitory concentration index. So this FICI value is just a ratio of the MICs of the compounds together versus alone. And a low FICI value tells us that the compounds work better in combination. So they're potentiating one another. So this graph tells us that Bay and penicillin G do indeed potentiate one another. Penicillin G, of course, is a beta-lactam antibiotic, which inhibits the transpeptidase domain of penicillin binding proteins, or PBPs. And in Staph aureus, it particularly targets the transpeptidase domain of PBP2, which is an essential PBP in Staph and the only bifunctional PBP. So one interesting thing that we're starting to unravel in the lab is what beta-lactams does Bay synergize with. And so far, it seems like beta-lactams that primarily inhibit PBP2, like Cloxacillin and imipenem shown here, all synergize with Bay, as identified by their low FICI values. But if we instead move to beta-lactams like methicillin or cefazolin, which primarily target other PBPs in Staph, we start to see higher FICI values, suggesting that Bay no longer synergizes with these beta-lactams. So just kind of as a quick summary, we found that Bay is a synthetic anti-inflammatory that stimulates Pseudomonas biofilm formation. And through some medicinal chemistry, we were able to optimize it to have activity against MRSA, resulting in the synthesis of our additional scaffold here, PSPC. Using both Bay and PSPC, we attempted to uncover the molecule's mechanisms of action, but that still remains a mystery. So something we're still continuing to try to piece together and figure out. But somehow Bay is interacting with beta-lactams that primarily target the transpeptidase domain of PBP2 to restore sensitivity of MRSA to those traditional beta-lactams. This could be occurring through a variety of different ways. It's particularly interesting for us since MRSA strains contain an additional PBP, PBP2A, which is beta-lactam insensitive, but they still rely on the glycosyltransferase domain of PBP2 for cross-linking the bacterial cell wall. So if BAE is somehow resulting in mislocalization of PBP2, it would interrupt that interaction and potentially be resensitizing MRSA to penicillins. But determining exactly how that link is happening is something that we're still working on figuring out. So next steps for this project is trying to figure out how we can explore that interaction and exactly how BAE is potentiating these beta-lactams. And is this something that we can take advantage of in the future to identify potent antibiotic adjuvants? Another important part of this is our end goal would be to identify compounds with the same mechanism as BAE, but move away from that original structure, since of course BAE is an anti-inflammatory, and that could add all sorts of complications. If we want to use an anti-inflammatory to potentiate beta-lactams, how does that affect the patient's immune response and their natural ability to fight off infections? So lots of important things to think about there, with an end goal of identifying a new scaffold that lacks that anti-inflammatory activity, but can still potentiate those classic beta-lactams. So just a quick thank you to all of the many collaborators who have helped out in this project. And thank you to Dominik for his amazing talk and introducing this staff story, and to everybody for coming out very early on a Wednesday morning. I will pass it back to Lori.
Thank you very much, Victoria and Dominik and Deb as well. So I encourage the audience to post your questions in the Q&A, and then we can answer them during this session. So there's a question from Padman, I guess maybe for Deb, asking about using the BLAZ PCR as a confirmatory test for this penicillin phenotype that you're using disc diffusion to assess.
So Padman, that's a great question. I know you have some expertise in that area. So yes, that is considered the gold standard. So it's more how to incorporate that routinely in the clinical lab. But yes, that would definitely be an option for those labs that would have access to that.
Hey, thanks, Deb. I actually have a question about because the SNAP trial is international, how much of the antibiotic selection is based on local resistance patterns? So, you know, would Hamilton, for example, have a significant amount of penicillin sensitive staff that would make you comfortable using penicillin?
I'm not sure whether Deb has any data already at this point, but I mean, it doesn't matter, right? The way it's set up is, regardless of into which category it falls, you can enroll patients and they will be randomized to one or the other arm. If we have a much lower than expected penicillin susceptible Staph aureus rate, then we will have a very small number of patients to contribute to that study arm. But beyond that, it doesn't really matter given how the platform is built up. There was even the option that if you're unable to do the PSSA testing, that you would consider PSSA under the MSSA group and would just randomize there between Cloxacillin and Cefazolin. So the way it's set up, it opens it up for every type of epidemiology that you may have locally. Deb, anything to add?
No, I mean, this actually will be interesting because we will be able to generate some epidemiological data. I was going to reach out to some of the Canadian sites who have already started to see what their rates of penicillin susceptibility and resistance are, you know, incorporating not only the MIC, but the disc and the zone edge. So I'm going to be quite curious to see what our epi is, but certainly there's a lot of papers out there that have shown that penicillin susceptibility is around the 10–20% mark at this point. So certainly worthwhile looking into it.
Well, maybe Victoria can help improve those numbers with her compound. Okay, there's a question from Dr. Coombs for Victoria. He asks, the FIC between BAE and PBP2 and 3 targets seem additive. Does this give you a clue about the potential target of BAE?
Yeah, so the interaction between BAE and beta-lactams that target PBP1 or 3 isn't quite additive. It's kind of in that intermediate zone. So I think there isn't much of an interaction there. But I have seen a couple of interactions with BAE and other cell wall targeting antibiotics that are a little more additive. So, or not additive, sorry, they disrupt the activity. So for example, BAE kind of decreases activity of something like vancomycin. So it's possible that that can give us a clue about its mechanism of action. In terms of the antibiotics that it has more of an additive relationship with, that could also be a very important clue. So it's possible that it's mimicking those antibiotics or somehow interacting with them a little bit more similarly in such a way that it's not able to potentiate them. So I'm in the process of kind of going through a variety of different beta-lactams to sort out which ones have an additive relationship and which ones have this potentiation relationship to see if I can start connecting the dots there between those phenotypes.
It's been a detective story. And Victoria's been very patient trying to figure this out. Okay, there's a question for you from Dr. Miller. He says, wonderful presentations by everyone. Thank you. Victoria, for bacteria that can form biofilms and also have planktonic states, do you think it would be most effective to co-treat with antibiotics that treat both states simultaneously? Or if there were antibiotics that were specific to each state, would a sequential approach be preferred? So to treat biofilm and then planktonic?
Yes, this is something that we've thought about a lot in the lab. The story I told you today was about a compound that stimulates biofilm, but we have also been exploring compounds that inhibit biofilm formation. So there's some possibility to treat with a biofilm inhibitor in an attempt to shift bacteria towards a planktonic growth state, and then add an additional antibiotic to try to wipe out the planktonic growth. But we don't have kind of an excellent candidate molecule for that yet. So that's something that we're hoping to possibly do in the future.
Thank you, Victoria. I had a quick question, and you probably have told me this, but I'm going to ask you again anyways. So the resistant strains that you raised to BAE and PSPC, what is their susceptibility to beta-lactams? Has it changed? Like even in the absence of your compounds, is there susceptibility to these PBP2 targeting beta-lactams any different?
So I haven't tested my whole panel of beta-lactams. I think I've probably only done penicillin G, and susceptibility for the BAE-resistant mutants is the same as for the parent strains for penicillin G. But again, it's possible that different beta-lactams will have different sensitivities there.
Okay. And I have a last question for Dominik about the trial again. So this trial is directed at patients with staph bacteremia specifically, or are you also enrolling patients with other pre-bacteremia staph infections?
No, the enrollment starts once you have identified Staph aureus. So it's specifically for Staph aureus here. I mean, when you think about, you could enroll them early if you said any gram-positive cocci in a blood culture kind of thing, but then the majority will be coagulase-next staph, which often you don't have to treat to start with. So that's why the decision was made. No, we can only start enrollment once you know that it's a Staph aureus, which has the downside that you lose time at the beginning, right? Until you can randomize. So you sort of resort back to the empiric management in the first 1 or 2 days until you know it's Staph aureus, and then the enrollment starts, and then you get out of that random care into randomized care. It would be great if we could do so earlier, but I think given the situation with most of the gram-positive cocci not being Staph aureus eventually, I think it makes sense the way it's been set up, but it comes with downsides, and the quicker we know it's Staph aureus, the better.
Well, hopefully those downsides are mitigated by the scale of the trial, right? And enrolling so many patients.
No, absolutely.
Okay.
I mean, it will be adding noise, but hopefully the plan at this point is roughly 7,000 patients internationally to enroll into this study. So that should offer enough of a signal eventually.
Great. All right, I don't see any more questions popping up. So I would like to thank our speakers for today for excellent talks. Bravo. Thank you everyone for joining us this morning, and we will see you in October, the first Wednesday of the month, same time, same place.